Director of Population and Public Health Services for the region, and I had the pleasure of being co-lead for Rpiw 62, and we're going to speak to a talk time of 20 minutes. Our team members will introduce themselves as they present, and we're going to show you our team photo. We are the Pinkerton Detectives. I'd like to thank one of our team members, Patty, who was so diligent she woke up at 2 in the morning to think of our day. Thank you, Patty. I'd also like to say that we worked really hard, as you can see by that photo, because none of us resemble the photo. So the improvement title for our Rpiw is to eliminate errors of missing pink sheets to health records upon patient discharge from emergency. The theme is to ensure patient safety by having the right information at the right place, at the right time, accounting for every emergency pink sheet, resulting in accurate NACRS data. And NACRS is the National Ambulatory Care Reporting System. So our current situation was that pink sheets, a document with initial patient diagnosis, are needed back in health records upon discharge to account for the emergency visit, and they do impact continuity of care. 79 to 129 patient pink sheets out of about 2,100 per month don't always return from ED to, after patients are discharged, to health records. And that results in a lot of searching by emergency room and health record staff in the back rooms and shelves, drawers, etc. Patient pink sheets travel a lot within a department and between departments, which always increases risk of losing them. There was a lack of awareness in the number of missing patient pink sheets on a regular basis in ED, and also a lack of awareness of the important information that's on those patient pink sheets. The communication breakdown from missing pink sheets results in can impact patient safety, so we were very concerned about that. You can see at the bottom of our process, our project form is the process flow, and it started when the patient is discharged from emergency and carries on, the pink sheet carries on through a number of processes until they're actually filed down in health records. Our PQA data shows the number of missing pink sheets after 48 hours of discharge. This was tracked for 2 months from January 23rd right through to March 23rd, and as you can see that there was a significant amount of pink sheets missing each week in that period of time. So what is a pink sheet? There might be some people that don't know what this is. It's actually a legal document of a patient visit, and in addition, it's utilized for data entry at different points during the process. There are a number of things on this sheet that are very critical pieces of information that are needed for data entry, and that includes making sure that we have the attending physician name on there, client's demographics, of course, including their postal code, the triage status noted by the nurse at triage, final diagnosis, and their discharge date and time, as well as the physician signature, in addition to some of the other documentation. So this is a picture of our current value stream map at the beginning of the process, and we had 12 starbursts that we noted when we were going through and looking at the process. Our lead time was quite long, and we had a range, and I'll speak to why that is in just a moment, but the range was from 2 days, 6 hours, 29 minutes, 5 seconds, to 3 days, 5 hours, 59 minutes, and 5 seconds. And that's due to some of the weights. You'll notice that the weight between patient pink sheet sorted by, or patient pink sheet discharged in WinKISS to the time that it's sorted by the emergency room unit clerk is a range of 30 minutes to 24 hours. And that's because those pink sheets can continue to be discharged in WinKISS as they're actually discharged from emergency. And so we're looking at a 24-hour period. The other long wait time that we found was the 48 hours that those pink sheets waited from the time that they were down in health records from the time they arrived there and were sorted to the time that they were actually verified against the registration list at one of the other deaths down in health records, so that was 48 hours. Our lead time, we decided to stop at this part of the process when we looked at the map, because there is a 3-week waiting time until the data goes into NACRS, and we didn't feel that we could influence too much at that end of the process. We felt that we could do a lot of work in the process before that. Our value added time at this point, percentage value added was 4.8, and non-value added was 95.2. So we did some timings, pre-Kaizen, and that was from the patient discharge from emergency right down to the time that that pink sheet was verified from the registration list. Our TAC time was calculated around pink sheets that are coded in NACRS. So we looked at the total minutes that we had available from the health information practitioners, and that was a total of 450 minutes a day. And then there's approximately 80 pink sheets or patients put through emergency each day on average, and so that gave us a TAC time of 5 minutes and 38 seconds to enter pink sheets into NACRS. We did a fishbone analysis to look at our problem, and pre-Kaizen we identified 13 factors that were contributing to the loss of our pink sheets, and post-Kaizen we were able to address 8 factors, giving us only 5 remaining for a 62% improvement. Our spaghetti diagram is the pink sheet travel within health records. It starts off at the outpatient's desk there over on the left-hand upper corner, travels over to a shelf after they're finished their work with it, waits there for 48 hours, and comes down here to the health records clerk, where it is verified against the registration list, goes back to the shelf to wait until it can be entered in to NACRS database, then goes from the desk there over to the filing cart waiting to be filed. And that gave us 91.5 feet. Target progress report, our pre-target progress report, the part travel, as I mentioned, was 91.5 feet. Our target was to get that down to 46 if possible. Our lead time, we didn't focus too much on just specifically timing, but we did hope that we would be able to reduce it from that 3 days and 5 hours and 59 minutes and 5 seconds to a lesser time. But we wanted to really focus on the quality. So the number of missing patient pink sheets in health records to start with was at 7.5%, and our target was 0. And number of patient pink sheets in client access with missing or incomplete information was 12.3%, and again, our target for that was 0. Our setup time for health records outpatient desk, where they were doing the pink sheet and charge assembly, was 1 hour and 30 minutes. Our target for that was 1 hour, and the cycle time for the emergency unit clerk for final sorting of the patient pink sheet for delivery down to health records was 1 hour and 45 minutes, and our target for that was 53 minutes.
Good afternoon, my name is Georgie Jacob. I'm a health information management practitioner and also a participant in this Rpiw. In the process to determine missing pink sheets, we realized that a significant percentage of the missing pink sheet arise from patients leaving the facility prior to triage. This was due to handing over the pink sheets directly to patients post-registration. We decided to change this route of delivery by giving the pink sheets directly to the triage nurse post-registration. To achieve this, we were able to place a file folder between the client access and triage, wherein the pink sheets could be placed at one end and the triage nurse could access the documents from the other. This helped us prevent one key step that contributes to missing pink sheet. After implementation of this step, these changes in the process were also conveyed and notified to the patients by placing a notice in the registration area. This was the notice. Finally, we also reminded the triage nurse to make sure that the required mandatory fields in the pink sheet, such as checking off the CDAS level scores, were complete before forwarding it to the emergency room to prevent further movement of the pink sheets back and forth between ER and client access for completion, which may lessen the chances for the pink sheets to be misplaced.
Hi, my name is Lori Tomyak. I'm a unit clerk in the emergency department. Throughout the week, we have completed a work standard for the client access clerks and the day-evening unit clerks. Training has been provided throughout the week with the emergency unit clerks, as well as discussing the flow of pink sheets with the managers from client access. By having the pink sheets sorted by date by client access clerks and sorted numerical by ER clerks, this allows us to identify and look for pink sheets in the ER prior going to health records. This change will significantly reduce the number of pink sheets lost in ER.
Hello, I'm Jody Hazelwood, Patient Family Advisor on this very vital RPIW. As a Patient Family Advisor, I realize and cannot stress enough the importance of those pink sheets not leaving the ER. Since 79 to 120 sheets go missing from the ER on a monthly basis, and the ER has now posted a sign that requests no pink sheets to be taken beyond this point, and they're posted on the ER doors. The pink sheets can be photocopied, or else the white sheets can be taken. Further communication is seen by information posted in the stress lab and the surgeon's dictation room. Again, requesting that the pink sheets not leave, or pardon me, be returned to the ER. Thank you.
Hello, I'm Sheila Cooper. I'm a registered nurse in acute care, and I was a participant on this team. So we identified two different areas where pink sheets were going and not being completed properly. So one was pediatric patients coming into the ER, being taken up to the treatment room to have IVs started or different treatments, and their pink sheets were never getting back to the ER. So we developed standard work for the ward clerks in the pediatric ward. We collaborated with the nursing unit manager and the ward clerk, and there's only 2 ward clerks. So we were easily able to train those 2 ward clerks and the manager, and they will now take the pink sheets back to the ER so they can be properly discharged. We also collaborated with the ER physicians, as they have the majority of the responsibility for filling in the mandatory parts of the pink sheet. Those parts are actually put in health records, and so that helps us with funding, and it's also a patient safety requirement. So we mostly talked to Dr. Russo about what the best way of communicating these things were. And so we decided we would just make pink sheets with the proper areas that need to be filled out. And we kind of posted them everywhere. We put them in the ER physicians' baskets. And we also hung them up in various places in the ER. And there is standard work with that as well. Tammy Gillis also helped us to make sure that the physicians in charge of residents in jerseys were aware of how they were supposed to fill out.
Hello, my name is Patty Betka, and I'm one of the 7 health information management practitioners and health records who are responsible for the collection of NACR's data from the pink sheets. That data is collected and sent to the Canadian Institute of Health Information in Ottawa, and the data reports are forwarded to the Saskatchewan Ministry of Health for their use in planning and funding. Our team created a communication tool regarding the importance of the pink sheets. This document was widely distributed throughout the hospital. One of the points on the document addresses the importance of complete data on the pink sheets. On the day prior to implementation of the team's changes, out of 83 pink sheets, there were 63 missing data elements. One day after implementation, out of 77 pink sheets, there were 26 missing data elements. On the second day after implementation, out of 72 pink sheets, there were 21 incomplete data elements. This is a very positive change.
Hello, my name is Beth Noble, and I'm the Health Records Clerk in that Records Department. So the shelf where the ER pinks are placed in the Records Department to be coded was overflowing as CIHM manuals and nurses' notes were also being stored there. These manuals and notes were moved so the piles of pink sheets could all sit on the shelf instead of overflowing onto a cart, improving office organization. The OPD clerk will no longer be sorting the pink sheets by date, as client access will now be, and the health records clerk will no longer verify pink sheets according to the ER registration list, as the ER clerk will also be doing this before sending the pinks down. Finally, since the ER unit clerk will now be looking for missing pink sheets in a timely manner, this will reduce the number of pinks health records staff need to locate weeks later.
Good afternoon, I'm Darlene Batty, the Director of Long-Term Care and the co-lead with our fabulous Pinkerton detective team. So we did a mini 5S in the transcription room, storage room. So these are some pre-5S pictures. So you can see there's a lot of clutter in some areas. We have a little mouse trap there in the corner. Fortunately, it was empty. The piece of machinery there at the bottom shelf was obsolete. So again, not necessarily to be stored there. Clutter on a table in that same room. There's a can crusher there on the wall that the efficient staff there use to crush the cans and recycle them so that they have some money for their staff funds. So we thought it best to just leave well enough alone, so we didn't do anything with that post-5S. Again, a shelf there against the back wall that's used very little. And the walkway is blocked with the coat rack there. This piece of the printing department, our printer is there. There's a power set up there on the floor on top of a folded incontinent or like the staff weren't even sure what it was there for, but apparently the roof leaks in there on occasion. And against the other shelf there is a wooden step that was no longer necessary. So our pre-5S score was 5.1. So we had some red tag items that actually quite quickly disappeared. And our post-5S pictures, you can see the great job we did there. We actually moved that big table out of there altogether. We hung the mirrors so that the staff could actually look at themselves before they started their day. And we were able to relocate that one filing cabinet against the wall. The hall walkway is no longer blocked. We were able to put everything into one filing cabinet, as you can see. The shelves are nicely labeled, so everyone knows where to put everything back. And our post score was 2.8. So our post-spaghetti diagram, we did, because of some of the changes that we made, the pink sheets no longer travel from the shelf to the health records clerk and then back to the shelf, because we changed that process. So we were able to reduce our feet to 76.5 feet, and those are all my feet. I walked the pre-spaghetti and the post-spaghetti. So our time observation form, post-Kaizen, the pink sheets being verified and sorted by the ED ward clerk, actually that cycle was increased because we added a lot of work to that point in the process because we wanted to really emphasize identifying the missing pink sheets and the defects early on in the process, rather than having it go further down the line. And the pink sheets being organized by the Health Records Department is actually decreased in time. So our post-Kaizen value stream map We still have a few outstanding starbursts because those are areas that we really couldn't work on in this process. So as you can see, we have eliminated one step in our value stream map. So our lead time was improved considerably simply by eliminating that 48-hour wait in the health records department. So I already talked about the change or increase in our cycle time, but we again, our team expected that because we changed the work in the ED department. Our value added percent is 13.1% and our non-value added 86.9%. So again, improvements in both of those. Our target progress report results. So for park traveled, we talked about that already. So the percent change is 16.29%. Our lead time, 61.20% change. The number of missing pink sheets in our health records department, again, the target we hoped was 0. So far we've seen a percent change of 62.67%. And the number of missing pink sheets in client access with missing or incomplete information, target of 0 there as well. So we had a percent change of 34.15%. And I understand today so far there are only 2 missing pink sheets today. So that is well done for the team. And our setup time, 22%, and capacity 27.5%. Our cycle time I mentioned already, so that's a percent change of 37.90%. So our newspaper, a lot of our items are 100% completed as well. We do have a few outstanding areas to address. Policy regarding the ER discharge and completion of pink sheets according to national standards. We had that identified on our fishbone diagram as well, because we really could not find a regional policy on that. We used all the resources that we could think of to research it and couldn't come up with anything. So we thought that was something that might need further consideration in the future. And we also have our multi-skill, our training for our staff in the ED department and our client access. So lessons learned, really a lot of things, I think our whole team learned a lot of things about the pink sheets and the importance of the data having significance in several areas. Client access wasn't aware of the information that health records needed and vice versa. So we also learned that departments really need to be, or became more aware of what they actually do in other areas that impact each other. And some patients were leaving with their pink sheets. So just by changing that one simple process, all of the residents or patients that were there, even if they left without being seen, we still had the pink sheets. So that was an improvement as well. Our workshop summary, we developed communication flyers for lots of different areas to communicate the importance of the pink sheets and how they impact patient safety. A number of new processes were developed as well as some work standards. We changed the sorting and verifying of the pink sheets, again at the ER desk instead of down in health records in order to catch the defects in the process early and then improve quality. And we provided all providers with a sample of an accurately completed pink sheet. So thank yous. I'd like to really thank our team. They were so full of energy and great ideas right from the start. Even, you know, some days we were more organized than others, but they were ready to go no matter what. The staff in all of the departments, the ER department, there was actually a code orange during our event week, which meant a large influx of patients at one time. Our client access staff, health record staff, the staff on pediatrics, the staff in transcription department where we did the 5S were very cooperative and saying, well, I don't even know why we have this here. What's the mousetrap doing there? Tammy was very open to suggestions, and she'll have a fair bit of work to do coming up. And she would just say, oh, here comes that RPW team again. Thank you to Charity and Cindy and Pat Stewart for all of their support through this project. I'd also like to especially thank Jody Hazelwood, our patient family rep. She had lots of different things occurring this week in her own life, but she managed to contribute a lot. She was actually a health records information person in the past, so that was great to have her on the team. And of course, last but not least, Sam the man, our CIO. We had occasionally, bring Wanda and I back to the purpose of our roles and making sure we had our I's dotted and our T's crossed in order to get our recertification. Just in case you all never knew this before, Sam doesn't know pink. So, orange is the new pink. Thank you very much.